Hello, class. This presentation will cover chapters 26 and 27 in your textbook. If you refer back to your course syllabus, you will note that chapters 26 and 27 have very few learning objectives to be covered. And so therefore, since both chapters will be covered in the same lecture day, I've consolidated them for this presentation. The learning objectives for both chapters combined are detailed here. They would include to explain the impact of maternal diabetes mellitus on the newborn. We want to compare the characteristics and the potential complications that influence nursing management of the post-term newborn and the newborn with post-maturity syndrome. And we need to define those separately so that you understand the differences between them. We want to discuss the physiologic and behavioral characteristics of the new preterm newborn that predispose each body system to various complications that are used in the developing of a care plan. We also want to explain the special care needed by the newborn for those exposed to alcohol or drugs. We want to identify nursing responsibilities and rationale in caring for the newborn receiving phototherapy. And we also want to describe the nursing assessment that would lead the nurse to suspect a newborn of sepsis and the nursing management of that newborn with an infection. So chapter 26 is titled The Newborn at Risk Conditions Present at Birth. There are many conditions that will be present at birth for a newborn, but we're not going to discuss those in any great length in this particular presentation. Some of those things that you may encounter at birth are some things that are extremely rare. We don't see them quite as often. We want to prepare you for the things that you may see most often in practice. So your learning objectives for chapter 26 would include, we want to talk about the maternal diabetes mellitus on the newborn. We also want to talk about in comparison characteristics between that post-term newborn and a newborn with post-maturity syndrome, which I discussed a little bit earlier. We want to discuss the physiologic and behavioral characteristics of the preterm newborn that predispose each body system to various complications that are used in developing a plan of care. And then we also want to talk about the alcohol and drug exposed newborn. So first, let's talk about the impact of diabetes mellitus on the newborn. This content can be found in your textbook in chapter on pages 573 to 575. There's also information in your ATI book regarding the management of the newborn to the mom with gestational diabetes. So the impact would include large for gestational age due to the high levels of maternal glucose. Um, some babies may also be born small for gestational age if the mother has vascular complications. These vascular complications would involve the transfer of blood flow between um, the placenta through the umbilical cord to the newborn. If there's any compromise with that blood flow, then the baby will not receive the nutrients needed to grow in utero. And so, therefore, although the mom may meet or reach uh, full term or term gestational age, the baby may be born small relative to the amount of the gestational time. There's also the possibility for hypoglycemia, which generally is onset between 1 to 3 hours after birth. And the baby may experience a severe drop in their glucose levels as related to the cutting of the umbilical cord. We also find that the babies may have a problem with hypocalcemia. All of these things are discussed on pages 574 in your textbook. hyperbilirubinemia, which is the accumulation and breakdown of red blood cells in a baby's system. And so they are unable to break down and excrete that byproduct of the breakdown of the red blood cells, which leads to hyperbilirubinemia. There's also the risk for birth trauma. When you think about the babies that are large for gestational age relative to maternal gestational diabetes, these babies may be difficult to deliver vaginally, and so therefore they may be subject to some birth trauma. There's also the risk for respiratory distress syndrome for these babies because of maternal hormones may be speed up the growth of the baby, but they may not have the maturity of the lung tissue that is needed to sustain that respiratory effort. And so they may have some complications related to respiratory distress. In addition to that, there may be some congenital birth defects that are associated with this increase in maternal glucose levels. These include transposition of the great vessel, ventral septal defects, patent ductus arteriosus. Some of them may also have a small left colon syndrome, renal anomalies, neural tube defects, and sacral agenesis, which is a caudal regression. Remember, when you learned earlier on with fetal development, how the fetus grows from the time that the implantation or fertilization of the egg to the implantation into the uterine wall. So they grow in that head to trunk caudal position. So there may be defects at the lower end. And all of this can be um, can be circumvented, or at least the risk factors lowered if we can monitor mom's glucose levels early on before the pregnancy, and this will also decrease the risk of any birth defects. There's more information discussing birth defects related to gestational diabetes in chapter 14, which will probably has already been covered or will be covered. So maternal gestational diabetes, we want to encourage the mom to control her glucose levels before birth so that we can decrease any untoward complications at delivery. We want to closely monitor and observe the baby for the first few hours to the first few days after birth. Monitor for hypoglycemia and polycythemia. Infants may also experience some mild hypoglycemia, and if they do, early feeding should begin. Early feedings will begin, hopefully, the mom will be preparing to breastfeed and maybe expressing some colostrum to give to the baby. And if colostrum is unavailable or mom is not able to breastfeed, we may even offer early formula feedings. So, nursing care of the infant of the diabetic mother, we do want to determine the glucose levels. We can do this by cord blood sampling or by heel stick. Cord blood sampling is the most accurate, but that's immediately after delivery. We do want to know what the baby is doing after the baby is delivered and once the umbilical cord has been cut. So we're going to do that via heel stick. This should be done early for the first 4 hours, and then at every 4 hour intervals until the risk period has passed. This is generally around the 48-hour time frame. Remember that most recently for vaginal deliveries, babies and mom may not be in the hospital for an extended period of time. They're usually discharged home after 2 days. But for the baby that is born to the mom with gestational diabetes, they may keep that mom and that baby in a little bit longer if there is some concern about the baby being able to maintain their glucose levels. early feedings by breast milk or formula, we do want to keep the baby's glucose levels greater than 40 milligrams per deciliter. And you do want to actually follow your facility's protocol. Some of them may say 45, some may say 40, but the rule of thumb and generally in practice, it is 40 grams per deciliter. If blood glucose levels could not be maintained through oral feedings, then they may be required for the baby to start IV infusion. This is generally with D10W. I want to draw your attention to the safety alert on page 575 in your textbook that says when infusing either a D10W bolus or a constant infusion, be careful not to administer too much glucose too fast in order to prevent hyperglycemic induced insulin secretions. So there is such a thing as giving the baby too much glucose too quickly, which can also rev up their pancreas to excrete more insulin. And so therefore, when you take away the glucose infusion, you have a dramatic rebound hypoglycemia, which is just as detrimental as the high glucose levels. It is also a best practice to start an IV glucose infusion at 4 to 6 milligrams per kilogram per minute. So that means that you're going to multiply the baby's weight in kilograms by the either 4 to 6 milligrams, and then do that per minute to avoid that rebound hypoglycemia. And this is for those babies that have a very, very narrow threshold for maintaining their glucose levels. So, to review, management for an infant born to a mother with gestational diabetes, we do want to monitor glucose levels hourly after delivery until stable. Then we want to monitor them every 4 hours for the first 48 hours consistently via heel stick. And this may also be based on your facility's protocols, but this is generally the standard of practice. We want to encourage early feedings, preferably breastfeeding, colostrum if available. So you do want to get mom to put the baby to breast. The sooner they can put the baby to breast, the sooner her milk can come in and she can produce that colostrum early on. If colostrum and breastfeeding is not available, then formula feeding may be necessary to give to the baby, especially if mom does not plan to breastfeed. We do want to maintain their glucose levels greater than 40 grams per deciliter, and you do want to make sure that you're following your facility's protocols. We want to monitor the baby closely for signs and symptoms of hypoglycemia. These were to include tremors, cyanosis, apnea, temperature instability, poor feeding, hypotonia, and seizure in severe cases. I want to caution you that a baby that starts to become apneic, have temperature instability, poor feeding, hypertonia, or even seizures, these are late signs of hypoglycemia. Early signs would include those tremors and maybe even some jitteriness and glucose instability. So you do want to monitor very closely and very carefully these babies. We do not want them to get into trouble. If we are unable to maintain a blood glucose level, then we may need to prepare the baby for an IV infusion of D10W. In most cases, these babies who have this very narrow threshold of glucose management will need to be monitored in the neonatal intensive care unit. We do want to obtain serum glucose levels for any reading below 40 grams per deciliter. So if you do a baby's blood sugar and the monitor comes back and it says that um, the blood glucose level is less than 40, you do want to repeat that glucose level. Maybe warm the baby's heel, maybe the baby might be cold, and so you're not getting an accurate reading. If after you repeat that and the blood glucose level is still less than 40, you want to notify the practitioner or the provider and also be prepared to get a serum glucose level where you're going to send a specimen off to the lab. You do want to monitor for signs of birth trauma in these babies because, like I said before, they can be very large for gestational age. They have an increased risk for brachial palsy, plexus injuries, for head trauma, cervical collar injury, and things of that nature when they're born vaginal. We do want to monitor for signs of hyperbilirubinemia. Hyperbilirubinemia, if not treated, can lead to brain damage, and so we do want to make sure that we're monitoring that very closely. Monitor for signs and symptoms of respiratory distress as well. So, post-maturity and post-term and post-maturity syndrome. This information is contained in your pages 575 to 576 in your textbook. So, first of all, let's define what the term post-term newborn means and what is post-maturity syndrome. A post-term newborn is any newborn born after 42 weeks completed gestation. Okay, this is a result of a prolonged pregnancy, and the baby can be of normal size, but they are continuing to grow. Generally, these babies weigh in over 4 grams at birth. Post maturity syndrome is also the baby that has completed more than 42 weeks of gestation. But these babies may begin to lose weight. They may have a normal length, but they're in head circumference, but they're actually the baby's appearance will be maybe even appear wasted as though they're losing weight or have begun to lose weight while they were in utero because they were hanging out a little bit too long. So, comparing some characteristics and potential complications, the post-term newborn may be macrosomic. Macrosomic is a large baby. They may experience hypoglycemia or hyperglycemia. They are subject to cephalopelvic disproportion. That means that the head circumference is larger than the maternal pelvis. They may have shoulder dystocia, brachial plexus injury, and they may even be susceptible to meconium aspiration syndrome. As the babies become very stressed when they are post-term in utero, their anal sphincter may relax and they may pass their meconium, which is their first bowel movement, into the amniotic fluid. Post-maturity syndrome newborns may be small for gestational age. So they have been in utero for 42 weeks or greater, but they're starting to lose weight and become smaller for their gestational age. They may lack the brown fat or extra adipose tissue that you will see in most term neonates. They may experience hypoglycemia as well as hyperglycemia. They may become polycythemic. Some of these babies will be born with congenital anomalies related to that advanced uh, age, gestational age. They may be prone to seizure activity. They may experience cold stress, and the cold stress is related to the wasting of the brown fat and that adipose tissue that they kind of put on in those last weeks of gestation. Um, as a result of some of the stress related to them being in utero, these babies also may relax their anal sphincter and pass their meconium into the amniotic fluid and be at risk for meconium aspiration syndrome. Some nursing diagnoses that are uh, that may you may find with regard to these babies would include hypothermia related to a decreased liver glycogen and brown fat stores, nutrition imbalance less than body requirements related to an increased use of glucose secondary to in utero stress, and decreased placental perfusion. They may have impaired gas exchange related to airway obstruction from meconium aspiration, and they may also have ineffective peripheral tissue perfusion related to increased blood viscosity caused by the polycythemia. These nursing diagnoses are also located on page 576 of your textbook. So to review, management for the post-term and post-maturity syndrome neonate are similar to those for the infant born to the mom with gestational diabetes. We do need to monitor their blood glucose levels hourly after delivery until stable. And then we can probably advance to Q4 hours for the first 48 hours consistently with heel sticks. We want to encourage early feedings, preferably with breastfeeding with colostrum or even formula feeding. These babies, the post-term and post-maturity babies, especially those who are small for gestational age, are often categorized as ravenous. Like they are eating and they are eating voraciously. Like they just want to eat everything in front of them. You have to be very cautious with feeding these babies because they can eat too quickly and set themselves up for aspiration. We do want to maintain their glucose levels greater than 40 grams per deciliter. We want to monitor for signs and symptoms of hypoglycemia to include those tremors, cyanosis, apnea. These babies are more prone to temperature instabilities because of this post-term poor feeding. Some of them, they may also be hypotonic, especially those with the post-maturity syndrome. And then late sign, very, very late sign would be seizure activity in severe cases. If the baby is unable to maintain their glucose levels, we are going to provide them with D10W. Remember, we're going to do from 4 to 6 milligrams per kilogram per minute for IV infusion, and that's usually the standard of care. We're going to obtain serum glucose levels for any readings below 40. We're going to monitor for signs and symptoms of temperature instability. We're going to monitor for thermal regulation and signs and symptoms of cold stress. And we'll talk about cold stress probably in another lecture. But it is going to be extremely imperative, especially for that baby with the post-maturity syndrome, that we monitor and maintain their temperatures. If they get into a situation where they're stressed or cold stress, they will quickly deplete their energy stores, which will then burn more of their fat stores, which will then exacerbate the hypoglycemia. So it is extremely critical. I cannot stress that enough for babies who are post-term, especially those with post-maturity syndrome, that we monitor for their temperatures and make sure that we keep them in that thermoregulatory setting. We want to monitor for signs and symptoms of respiratory distress and provide supplemental oxygen as needed. So, preterm newborn. We want to discuss the physiologic and behavioral characteristics of the newborn and the things that predispose them for complications and when we're developing a plan of care. So first of all, we have to determine what are we identifying as a preterm newborn, right? So preterm newborns are usually those babies born less than 34 weeks gestation, but we can also look at these babies for the ones that are small for gestational age, and then those would be those babies that are born less than 36 weeks, 6 days is what is considered a preterm. So a late preterm is that baby that's 34 weeks, 0 days to 36 weeks, 6 days. And so depending on the baby's gestational age, depending on their weight, you may see some of these smaller babies in your newborn nursery or in the room with moms because although they may be small, they're kind of mighty and they want to hang out and they're going to they may act a little bit more mature than what they are. But in any event, if they are even if they are late preterm, that still does not necessarily mean that they have to go to the neonatal intensive care unit, especially if they're maintaining their temperatures and they're feeding well. So an early term would be a baby that's 37 weeks 0 days to 38 weeks 6 days, and then full term babies or any babies that are 39 weeks 0 days to 40 weeks. And then we talked about those post term and late terms. So let's compare and contrast. So small for gestational age babies, those are SGA, or those that are born below the 10th percentile. And so in this course and in your pediatric course, you're going to be plotting babies and children's weights on a growth chart. And that's where you're going to get that indicator of whether or not they're below the 10th percentile, if they're within the 10th to the 90th percentile, if they're above the curve, where they should be based on what the average is for a newborn or for a child when you're graphing their weight. But for this particular lecture, we're going to talk about the small for gestational age. They may be preterm, they may be term, or they may post-term, maybe post-term. Remember we talked about those babies that are post-term or post-maturity syndrome that are small for gestational age. They may be term or post-term, like 42 weeks, but something has happened that caused them to be smaller than what they would have been if that complication hadn't occurred. So this is assigned by their birth weight, their head circumference, and their gestational age. The altitude and ethnicity. Maternal factors for this newborn could include smoking, hypertension. Just I want to add gestational diabetes can also be a factor. We do want to monitor for their mortality rate. They are a little bit better than those that are premature, appropriate for gestational age. And this is spelled out for you on page 566 through 567, where it talks about identification of the risk for the newborn and the care for those with small for gestational age and intrauterine growth restriction. I think it is important for us to discuss this, or for me to tell you about this, because we have found that there are so many babies in the uh, postpartum area that are not going to the NICU because they are meeting the weight requirement, and with their gestational age they are doing better, and they don't necessarily need to be separated away from their moms because they're maintaining their temperatures and they're being able to feed. So a preterm infant, or a preterm appropriate for gestational age, would be a baby that would be neonate that's 36 weeks, 7 days. And they are based on small for population between the 10th and 90th percentile. And these are also assigned by birth weight, by their head circumference, altitude, and ethnicity. And so maternal factors are the same as with the small for gestational age, but these babies are highest neonatal mortality rate. Um, and that is really related to the maternal factors that are associated with these babies. Then we have those that are intrauterine growth restricted. These are our IUGR babies. They're acute long-term conditions that restrict or limit the growth or development of the fetus when they're in utero. This is based on the growth potential of the fetus and during development. It follows an expected growth line in a normal pregnancy from 28 to 38 weeks gestation. A lot of times, intrauterine growth restriction is caused by maternal or paternal, maternal or placental, or even fetal factors, including maternal parity. So, depending on how many pregnancies a mom has had, this could impact the growth of a subsequent pregnancy. If there is any disease, sexually transmitted diseases, any maternal diseases that could interfere with placental development or transfer of placental blood flow. This could also contribute to intrauterine growth restriction. If there's any substance abuse or misuse, and there are also environmental factors that could impact intrauterine growth and could restrict the growth of the neonate. So morbidity and mortality is the infant's chance of death within the first 28 days of life. So that first 28 days is very critical, and the risk decreases as the gestational age and birth weight increases. So with that being said, the longer mom can stay pregnant and the baby can stay in utero and grow appropriately, the better chances this baby has of being born without limited amount of complications, and that decreases the mortality rate. Morbidity is based on birth weight and gestational age and helps to determine which infants need special observation and care. So the baby that you see on the screen in front of you is classified as small for gestational age. If you look at this baby, you may think that the baby might be preterm, but if you can look at the skin, you can see that they have little or no subcutaneous tissue or fat, but they have a small amount of breast buds, and there is some wrinkling to the skin that leads you to believe that the baby has been in utero for a little bit and has developed all of their fingers and toes and toenails and everything. There's ear cartilage on the baby, which speaks to their advanced neonatal or gestational age, and then the fact that they have very little lanugo over the trunk and other areas of the body. So they are small for gestational age. And these are the things that you want to be mindful of when you're doing your newborn assessment. So complications that can arise for babies that are small for gestational age or have a intrauterine growth restriction include fetal hypoxia. They're at risk for aspiration syndrome, hypothermia, of course, because they don't have that extra layer of brown fat, hypoglycemia, polycythemia, some congenital malformations, intrauterine growth, intrauterine infections, continued growth difficulties even after the baby is born, and some uh, cognitive difficulties. So nursing care for our SGA IUGR newborns, and we can look at the nursing care plan that's included in pages 570 to 573. Our most important thing that we want to do is decrease the physiological stress associated with this the baby and being born. So physiological stress, the environment, things like that that we can control. We do want to observe for subtle signs of change in clinical condition. If there's any temperature instability, periods of apnea or bradycardia, we do want to look at the vital signs and making sure that they are staying within normal limits. Interpreting lab values and laboratory data and coordinating those with the interventions. We want to cluster cares. So if we need to do lab draws or anything that we need to do for these babies that are SGA or IUGR, we want to do those things in an organized and a sequential manner so that we're not disrupting their care times or their time that they are resting. We need them to rest. We need to conserve their energy so that they can grow and they can continue to do well. We want to provide for developmental stimulation and maintenance of their sleep cycle. You will see that if you see these babies in the neonatal intensive care unit, if you have an opportunity to visit there, they have uh, daytime rituals and nighttime rituals where they will uncover the isolates. They'll raise the blinds to let the light in so that the babies get a sense of this is day and this is night. Also limiting the amount of stimulation from visitors and things like that so they can maintain their sleep cycles. Assisting families in developing attachment behavior. So when encouraging families to come in during care times so they can hold the babies and spend time with them, participate in their care, changing diapers and so forth and so on. Involving the family in the planning and providing of care. This is also included on page 566 to 567 of your care plan, where we talk about how we can manage the baby and things that we can do to to encourage their growth and development. Some nursing diagnoses that we do want to be concerned with for these babies with IUGR or SGA that are small for gestational age or have intrauterine growth restriction include hypothermia, imbalanced nutrition, less than body requirements, ineffective peripheral tissue perfusion, and then risk for impaired parenting. Remember that these babies are small. We do want to make sure that they are getting the rest that they need. They're getting the nutrients that they need. But we also want to promote bonding. That is extremely important for these babies so that they can, the parents can have a sense of this is their baby and that they are doing something that's going to help them to move their baby along and help them to do better. Some respiratory and cardiac physiology. These babies that are small for gestational age or that may be premature may have problems with their respiratory system, meaning that they may have insufficient surfactant stores, which can lead to increased atelectasis, will contribute to apnea of prematurity. There is a risk for the shunting between the pate and ductus arteriosus, which will also increase respiratory effort. And the baby that you see pictured here is intubated with an endotracheal tube, which you can see right here on the image. They also have peripheral IV access and a peripheral line here. This is probably going to be a peripherally inserted central catheter in this area, and you can see that coming down here. They are keeping the baby positioned for developmental growth and keeping the baby flexed the way that they would have been in utero. So alterations in thermal regulation. Remember that these babies are very small. They did not hang out long enough to get that nice adipose brown tissue that they need for insulation. So we need to prevent heat loss for them. We want to encourage mom to hold the baby skin to skin when she's visiting. That is the sweet spot right here where the baby sits between the mom's breastbone right there, and it's like that automatic heater. Higher surface area to body weight, so they have a higher surface area. They're smaller, so because more of their skin is exposed, they have a greater risk for the loss of heat. Their skin is thin and permeable, so therefore they are easily chilled. They may have a hypotonic position. Remember, those babies that are been in utero for a while, they have that nice flex position. They're holding their extremities close to them, and that helps to conserve their heat stores. They have a decreased ability for vasoconstriction to conserve heat, so therefore they're losing their heat. And most babies lose most of their heat through their head, as you well know, and so we want to keep their heads covered to keep them nice and warm. Their metabolic rate and oxygen consumptions are increased, so therefore if they're burning lots of calories, they're burning lots of oxygen, and so therefore that is going to increase their risk for alteration in their thermoregulation. Gestational age that directly proportional to the baby's ability to maintain thermoregulation. Thus, the more premature the newborn, the less able the baby is to maintain their heat balance. So therefore, it is going to be up to us to make sure that they keep their heat balance. And this is also true for those babies who are born small for gestational age but have that post-maturity syndrome. Remember, they were hanging out for a long time. They are gestationally, they may be term, but physiologically, they may have a greater need to have their temperature regulated and for them to maintain their body heat. Alterations in gastrointestinal physiology, there is a problem with ingestion, digestion, and absorption problems. So poorly developed gag reflex and incompetent esophageal or cardiac sphincter leads to poor sucking and swallowing reflux. They have a requirement for high calories and fluid needs, but their stomach capacity is very small. So therefore, we have to give them high calorie, high nutrient feedings to help them to maintain their body weight and to also keep their gastrointestinal tract moving. They may have a limited ability to convert amino acids and may require additional amino acids added to their formulas. They may have a high requirement for whey protein than casein because they have delayed ability to break those substances down. We may have to provide more. They may have a difficulty with absorbing saturated fats, and so therefore there may be a need to add some additional supplements to their regimen. Difficulty with lactose digestion. This is why it is extremely important to encourage moms to do breastfeeding. A lot of times babies will have difficulty digesting some of the commercial formulas, and so breast milk is easier to be digested, especially for those babies who are premature. So we want to encourage breastfeeding if at all possible. They may have calcium deficiency, increased metabolic rate, which I said before, which increases their O2 requirement. And so in feeding intolerance and risk for necrotizing enterocolitis related to diminished blood flow to the gut. So if they're having decreased blood flow to the gut because of other complications, it's going to make it difficult for them to absorb and digest any of the nutrients that they get. And so that is an increased risk for NEC or necrotizing enterocolitis. Some babies actually will have the their intestines die off. They may require surgery. Um, and so it is important to understand what's going on with the babies so that you know that. There may be an alteration in renal physiology, a drop in urine output related to a drop in blood pressure. So, if there is hypotension and there is not enough blood pressure to perfuse the kidneys, then there is going to be a drop in urine output. And then there is an increased risk for fluid and electrolyte imbalances. Nephrotoxic drugs can compromise renal systems. Remember, if there is a decrease in blood flow to the kidneys, there's a drop in renal perfusion, then the kidneys cannot filter things that blood, any type of medications that are broken down in the kidneys. So this can lead to toxicity and can be detrimental to the baby. This is also covered on page 578 of your textbook, where it talks about alteration in renal physiology. Okay. Alterations in immunologic physiology. So the preterm baby that's born with fewer antibodies, this is acquired in the last trimester of pregnancy. So remember I said the longer that the baby can stay and grow in utero, the better it is for the baby for mortality and morbidity. They acquire many of the antibodies that mom provides them in that last trimester of pregnancy. So it's important that we try to do everything we can for moms to help her carry through the last trimester. If not, then the baby has an increased susceptibility to infections that could be acquired in utero and are precipitated by this preterm labor and preterm birth, especially if there is a premature rupture of membranes, which can put the baby at risk for acquired infection in utero. Recurrent bacterial infections of the mom and her being treated for those can also affect the environment for the baby, which could also create problems. So there's a safety alert also on your in your textbook that says a sudden onset of apnea and bradycardia coupled with a metabolic acidosis in an otherwise healthy, growing premature newborn may be suggestive of bacterial sepsis, especially if a central line is present. I do want to bring that to your attention because that is extremely important for you to note, just in case you happen to be working with a baby and you're in practice, you've finished this program, you've gotten your nursing license, you're lucky enough to get a job in the neonatal intensive care unit or maybe in a newborn nursery, and you have a baby that may be a little preterm, you kind of watching them for a while, and then all of a sudden they just start having these very quick onset apnea and bradycardia, and they just keep having them over and over again. And then you notice that they're starting to exhibit signs of metabolic acidosis. This is very concerning and should be alarming and should just kind of perk up your suspicion that there may be some bacterial sepsis or something going on. Immature GI tract has increased risk for enteric infections. So, like I said, the younger the baby, the more um, the more the more at risk they are for mortality and morbidity. Alterations in neurologic function. This is related to the baby's neurological development. If there is an increased risk for interventricular hemorrhage, which is the ventricles in the head, then there is also the possibility for increase in seizure activities. There could be an increased risk for hydrocephalus. This is covered on page 579 in your textbook, where it talk about hydrocephalus can develop as a consequence of IVH, and this can be caused by obstruction of cerebral aqueduct in the brain. This is very severe. Babies that may have intraventricular hemorrhage can develop into seizure activity, and babies don't necessarily have those what you would envision as clonic tonic seizures that you would see in an older child or adult, where they're thrashing around or moving and doing those very overt movements or things that might clue you in that they're having a seizure. With babies with interventricular hemorrhage and the possibility of hydrocephalus and increase intracranial pressure, you will see very subtle signs. They may have a high-pitched cry. They may have some lip smacking kind of movements, rapid kind of eye movement, things that may be concerning. So those are things that you have to be aware of with babies who may have interventricular hemorrhage. Babies with IV catheter or central venous lines, they need to be managed very carefully for infection so that they don't get an infection that could also increase their risk for intraventricular hemorrhage. Also, uh, IV flushes. If you're with small babies that are small for gestational age or those that are very severely premature, very vigorous IV flushes can also increase intraventricular, the risk for intraventricular hemorrhage. Alterations in reactivity and activity periods. So when we talk about babies' behavioral states, we'll talk about those babies that have those periods of awakeness and sleepiness, and whether or not they're going to be active or inactive. This is discussed on page 579 in your textbook. Reactivity or delayed reactivity can be problematic with babies. We do want to make sure that they have organization in their sleep pattern. So if there's too much going on, they don't have an opportunity to get to organize themselves to be able to suck and swallow naturally, have those periods where they can be calm and get into a really good sleep pattern, then they get disorganized. They become awake very easily. This can interfere with their growth pattern. It also can interfere with their sucking, their neurological responses, and things of that nature. Um, if the baby is unable to attend to human faces or objects, this is problematic. It could signal that there is a problem with their activity or reactivity or their ability to focus on things. They may also have a weak suck, weak muscle tone, or difficulty with their arousal states. Nutrition and fluid requirements, very, 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 very important for babies that are either premature, small for gestational age, or have intrauterine growth restriction. Early feedings are extremely valuable to maintaining their metabolic rate and being able to lower their possibility of hypoglycemia. It also will help to ward off hyperbilirubinemia because early feedings will activate the gut and digestive system, allowing babies to have more frequent stools so they can get rid of the hyperbilirubinemia. So bilirubin is excreted in the urine and in the stool. So the more that we can get the baby hydrated and get them feeding and voiding and defecating, the less likely they will have problems with their bilirubin. They can also have hyperkalemia. We do want to make sure that we're making sure that we're monitoring the amount of fluids that they're getting. Osteopenia of prematurity is also can also be a problem. So making sure that they are getting their right amount of calcium within their system and looking for any problems with their digestive system. Breast milk or donor milk is preferred and can be offered to babies. Many of the larger hospitals are doing donor milk, and they have a milk donor bank where their milk is being screened and monitored very carefully so that it can be offered to babies who are either premature or have other feeding intolerance issues. Supplemental vitamins, including vitamin A, D, E, and iron, are also can be included to make sure that we're meeting the baby's nutrition and fluid needs. And there may be a requirement for some amino acids, calcium, phosphorus, or even vitamin D. This nutritional uh, uh, requirements and breastfeeding starts on pages 580 in your textbook. It talks about a clinical tip. The more preterm the baby is at birth, the longer it will take to reach the maturational state required to be successful for oral feedings. So we do have to take that into consideration and do caution moms who may have premature infants or those who may be small for gestational age or are intrauterine growth restricted to make sure that they understand that they may even require more feedings, like for a shorter period, times period, where some babies may be eating every 3 to 4 hours. Some of these babies maybe need to be fed every 2 to 3 hours, just so we can keep their fluid requirements and their nutritional requirements up. Um, Looking at the way that they're feeding, you do want to avoid excessive energy expenditure. So you don't want to try to feed them for too long of a period at a time. So you want to offer them maybe at least a half to an ounce of formula in the beginning, and their feeding shouldn't take longer than 15 or 20 minutes. If they're going more than 20 minutes, they're probably burning more of the calories that they're getting than they're storing for them to maintain their fluid and their nutrition requirements. So we do have to be cognizant of that and make sure that we're educating our parents on that as well. So long-term needs and outcomes for a preterm infant is we want to prevent lung disease or lung damage. We do want to look out for neurologic defects like cerebral palsy or hydrocephalus, seizure disorders. Some of these babies may have lower IQ, but that's not necessarily true. Some of them may also have learning difficulties and may be diagnosed with attention deficit disorders and things of that nature. Some of them may have vision disturbances or vision disorders, so it is extremely important that they see a pediatrician and they're being followed closely for vision and auditory and speech problems. So they need to see get their vision checked, their hearing checked, and see a speech pathologist if there is a concern with their speech ability. Preterm complications include apnea prematurity, and this is a cessation of breathing for greater than 20 seconds. Any baby that has any episodes of apnea will be monitored very closely and may need to be on cardio respiratory monitoring in the neonatal intensive care unit. We do want to monitor them for respiratory distress syndrome, the patent ductus arteriosus, and you will sometimes hear a soft murmur for these babies. Know that murmurs are sometimes benign, and that in the first hours after birth, you may hear murmurs as the ducts are closing, but for these extremely preterm babies, they may have a patent ductus arteriosus for a longer period of time, and some of them may even require surgical repair. Intraventricular hemorrhage is also a complication associated with preterm babies. Other physiologic problems include ingestion, digestive problems, absorption problems, immature immune system, which puts them at increased risk for infections, hypotonia, and delayed reactivity. And the page numbers associated with those particular information is included on the slide as well. And you know you can watch this as many times as you need to. So diagnostic labels associated with preterm babies, and I would even say those with small for gestational age, intrauterine growth restriction, those with post-maturity syndrome would include um, imbalanced nutrition, less than body requirements, impaired gas exchange, ineffective peripheral tissue perfusion, and of course, risk for injury. And that will be for both the premature and post-term or post-maturity syndrome neonates. Nursing care for these babies include maintaining their respiratory function, maintaining a neutral environment. We want to keep their thermal neutral environment so that they are maintaining their energy. We want to keep them warm so they're not using their energy to maintain their temperatures, but they're using their energy and their calories to grow. We want to maintain their fluid and electrolyte balances. We want to provide adequate nutrition by way of offering breast milk um, donor breast milk and any nutrition supplements that we may need to include. We want to prevent infection. This would include making sure that we're doing meticulous hand washing. We're keeping the environment for the baby clean. We're also educating the parents about proper hand washing and making sure that they're not visiting or having anyone handling the baby that may be be sick or have come in contact with any type of infectious agent. We do want to promote parent and infant attachment. I know a lot of times nurses want to protect the babies and they want to keep them all to themselves and keep them safe and secure, but it is really, really, really important that parents have an opportunity to interact with their babies and to build that maternal infant bond that they need to have. And that doesn't necessarily is isolated to the mom. All of the every parent, both the mother, the dad, if there is a LGBTQ plus couple that are fostering a child, or they're involved in a process. Any parent that is involved with this process should have an opportunity to attach with that infant and bond with that infant. It is extremely important for the family unit. So nursing management and goals for the preterm SGA IUGR infant assessment, diagnosis, implementation, and evaluation. Thermoregulation, skin to skin or neutral thermal environment is key. Maintaining the airway and oxygenation, effective breathing, free of respiratory distress. We want to make sure that we ensure a balanced nutrition, prevent fatigue during feedings, make sure that we're ensuring that the baby is having adequate weight gain and there's a prevention of aspiration, especially for those babies who are intrauterine growth restricted and they may be very ravenous with eating and trying to eat very quickly. We do not want them to aspirate or try to overeat. We want to maintain a fluid balance for them, prevent infection, prevent anything that coming into their environment which may contribute to an infection. Making sure that we're limiting venipunctures, heel sticks, IV sticks, um, meticulous hand washing, making sure that we're limiting exposure from people who may be sick, or making sure that everybody is maintaining aseptic technique when they're doing any type of procedures. If you see something, say something. That means if you see somebody break sterility, if they're doing something, you got to speak up so that the baby does not get an infection. Promote developmentally appropriate care. That means positioning, making sure that they are in a flex position so that they're conserving their heat and they're also promoting their growth. We want to promote family bonding and care in preparation for discharge. So, if families are visiting, allow them an opportunity to participate in care, encourage them to participate in care, encourage them to do family bonding, encourage them to come and visit during care time so that they can participate in care, and encourage them to hold the baby skin to skin to promote bonding. So let's move on to explanation of the care needed for the infant that is exposed to alcohol or drugs. Remember, when we talk about exposure of alcohol and drugs, drugs are not limited to illicit substances or illegal substances that the baby may come into contact with related to the mother. Okay, that is far from what we're talking about here. Although it is an occurrence, it is not the only thing that babies come in contact with when moms are exposed to drugs. These would include prescribed medications, medications for anxiety or schizophrenia. These may include over-the-counter medications. These may include medications prescribed for chronic pain. These may include also medications that people may share thinking that they're doing something good, and they are not. Okay, so we don't want to label or mislabel or say anything untoward about the mother, but we do want to be aware that these things happen, they exist, and their impact on the growing fetus. So Drug management, nursing management for the drug exposed newborn or neonate. We want to have an early identification of the clinical needs. So, if the mom is exposed or the baby is exposed during the fetal period, then we need to know that. That is going to dictate what you're going to do once the baby is delivered if there is going to be any untoward event. Assessment of clinical manifestations. I want to draw your attention to Table 26-4 on page 597 of your textbook. This is extremely important, especially related to the opioid crisis that we're currently in. When you think about COVID-19 and people being isolated and secluded and not being able to get into their providers if they have any type of mental health disorder and not being able to really talk to someone about it, um, sometimes people will resort to what they know, and sometimes that is using other forms of management of their um, mental disorders. So, things that we need to be concerned about or look at included in this table include nervous system symptoms, including a high pitched cry, hyper irritability, difficulty to console, restlessness, increased muscle tone, exaggerated reflexes, tremors. Myoclonic jerks, seizures is a late sign, sneezing, hiccups, yawning, snorting, short and um, unquieted sleep times, gastrointestinal signs to include vigorous sucks, excessive sucking, vomiting, diarrhea, poor feeding, and that means that the baby may feed, they may vomit, they may refuse to eat because of the gastrointestinal discomfort. Autonomic signs including stuffy nose, sneezing, yawning, mottling, tachypnea. This is a respiratory rate greater than 60 breaths per minute, even when they're quiet. So they're sleeping, but they're breathing like they're running a race. Sweating, hyperthermia. Cutaneous signs include excoriated buttocks, knees, elbows, facial scratching, and pressure point abrasions. These are clinical manifestations and signs of the baby that is having withdrawal symptoms and are having a very difficult time. It is extremely important that you identify these signs and symptoms early so that interventions can be implemented to help these babies and ease these conditions. We need to meet their nutritional needs. Many of these babies will need to have high caloric feedings to combat the over exaggeration of some of the signs and symptoms, as well as the increased metabolic rate associated with them. We need to assist the parents to help the infant with disorganized behavior and sleep. A lot of times these babies are very difficult to console. They cry excessively and it's very distressing to the parent, but we need to be very calm and we need to help these babies and help these mothers deal with these babies and their disorganized behavior. We need to monitor them closely for respiratory distress. Know that any baby that is experiencing any type of withdrawal can have respiratory distress, which can lead to respiratory arrest. Withdrawal symptoms, seizure activity, neonatal jaundice is also a big factor, and they also may have some congenital anomalies related to some of the medications that may be taken. Many of these are related to antipsychotic medications that are in a classification that should not be taken during pregnancy, and sometimes women may take their antipsychotic medications religiously and be unaware that they are pregnant. And then when they become pregnant, they become very depressed because they have now feel like now I've harmed my baby because I've continued to take my medications. So it can be a very distressing time for them. We need to monitor for their skin integrity, especially their diaper area. When these babies are going through withdrawal, they will have explosive diarrhea, which will quickly turn into a very, very bad case of diaper rash, diaper dermatitis, and excoriation to the point where it could potentially be bleeding. We do want to monitor for dehydration as a result of this explosive diarrhea and also vomiting. So we do want to replenish those things as quickly as possible and then try to make sure that we're administering the things that we need to administer to them to combat that. There is a nursing care plan on pages 600 to 602 that addresses this as well. I do also want to bring your attention to Table 26-5, which is a neonatal abstinence syndrome, signs and symptoms. It talks about central nervous system disturbances, metabolic disturbances, vasomotor disturbances, respiratory disturbances, and gastrointestinal disturbances. It also gives you some parameters there. Nursing management for the drug exposed neonate. We do want to look at what type of medication the mom was taking, when was the last time that she took something, and what was the dose that she took. A lot of times they will reveal this in their screening just before delivery, but sometimes they may not. They may need to bag the baby for urine to do a drug toxicology screening to find out what medications the mom was taking so that they know how to treat the baby appropriately. Um, what other things that I want to say? Most of your textbook talks about hospital-based care, but we do have to think about the baby that's going to go home, um, and what we're going to do and how we're going to care for them. Okay, so in the hospital, they're going to have neonatal abstinence scoring per the protocol. We're definitely going to be monitoring their temperature. We may have to at some point monitor their pulse oximetry and respiratory rate. Until they're stable, especially if they're very unstable. Okay, we may want to offer small, frequent feedings, especially if they have vomiting or diarrhea. We don't want to give them too much too fast because that just exacerbates the diarrhea, and then we're not getting as much things in them as we possibly could. We might want to look at their positioning and some things to avoid aspiration just in case they're vomiting. We do want to monitor their weights daily to make sure that they're getting all the nutrients that they need, and if we need to increase their caloric intake, that we can, so that we can make sure that we're bringing that to the attention of the provider. Some of these babies may need a oral medication to help them with their withdrawal. The most used one now is oral morphine or methadone. Previously, they were using tincture of opiate. Some babies may also need a dose of phenobarbital, especially if they're having seizure activity. Um, they will need to be swaddled. And also, you want to minimize some of the agitation that they may have and allow them to have that hand to mouth positioning where they can try to console themselves. Now, if they're digging into their faces and they're scratching themselves and they're harming themselves, then we may need to revisit that. But that's generally the best way to do. Provide some gentle rocking, offer some non-nutritive sucking, especially for those babies who have excessive sucking behaviors. Giving them a pacifier may help to calm them. And then also just to protect their extremities, you may have to put like soft mitts or something on their hands to keep them from scratching their faces. And then also keeping the environment to a point where the babies can be calm, especially during the evenings. Try to lower the environmental temperature and the environmental tone gradually so that they can become familiar with that wake sleep cycle and help them to self-console. So we're going to move on to chapter 27, which is a newborn at risk with birth-related stressors. For chapter 27, we're really just going to look at two objectives for this particular chapter. There is a lot of information in there, but we want to focus on these two main things. The first one being identifying the responsibilities and rationale for caring for the newborn receiving phototherapy, and to describe the assessment that will lead the nurse to suspect a newborn with sepsis and the nursing management for that newborn with the infection. So, care to newborn receiving phototherapy. So, phototherapy is a treatment for neonatal jaundice. What we want to do is expose the baby's skin as much as possible to the high intensity light, which is going to help the baby to break down the bilirubin and excrete it in either urine or stool. This allows a baby to convert this bilirubin and excrete it. Treatment may be via a bank light, which you see the top picture, or via a fiber optic blanket, which you see in the lower picture with the baby inside the isolate. If the bilirubin level does not drop to the appropriate level, then there may be the necessity for what they call an exchange transfusion, which may be considered. So, treatment of neonatal jaundice, a newborn temperature must be maintained. Remember that the baby has to be exposed, their skin has to be exposed so that they can be able to have the benefit of the high intensity lighting. Their genitals and eyes should be shielded to prevent injury. We should offer feedings frequently. Remember that the baby gets rid of the bilirubin by virtue of the breakdown of these red blood cells. Where the bilirubin becomes conjugated and can be excreted. So the more we feed them, the more they will urinate to get rid of this bilirubin, and the more they will defecate to get rid of the bilirubin. In addition to that, we want to offer them frequent feeding so that they do not become dehydrated. We want to monitor their bilirubin levels to determine the effectiveness of the therapy. So, in order for us to know if it's working, we need to send bilirubin levels off to the lab so that we can determine what the bilirubin levels are. There is a care plan associated with nursing care for the baby with hyperbilirubinemia, and it begins on page 630 and goes through to page 632. The nursing diagnoses shown in these particular care plans include impaired tissue integrity related to predisposing factors associated with hyperbilirubinemia, imbalanced fluid risk for imbalanced fluid volume related to phototherapy, and then thinking about that in terms of how are we keeping the baby hydrated so that they do not have an imbalance in their fluid. And then risks for impaired parenting. Think about it. Your baby has to stay under phototherapy for extended periods of time. So that means that there is a limited amount of time for maternal bonding or bonding with the other parent. We want to allow as much opportunity as possible for the mom to interact with the baby. So we do want to keep them under the phototherapy. We don't want to keep them away from the parents for an extended period of time. So the newborn with infection. So infection in a newborn is considered neonatal sepsis. Prenatal screening of the mother for infection is important so that we know what we're facing just in case the baby should have something once they are born. So this prenatal screening will be discussed when they talk about maternal implications in pregnancy. This is also screening done during the intrapartum period. We do have to monitor the baby and make sure that for mom, we're using sterile techniques during procedures, that we are using visual inspection to make sure that there are no lesions or anything like that in the vaginal area before the baby is delivered. And if there is a need for antibiotics for group beta strep, that is administered prior to delivery. And these things happen in the intrapartum period. This will be during labor and delivery. During the postpartum period, we do want to administer erythromycin eye ointment after delivery. This is to prevent any eye infection that may occur after the baby passes through the birth canal. Proper antibiotic treatment for maternally passed infections include chlamydia or gynecological infections. And then we need to assess the baby for nosocomial infections. Nosocomial infections are those infections that might be acquired by the baby while they're in the newborn nursery or in the neonatal intensive care unit, and these will be related to either procedures or equipment. There is in your textbook, they talk about antibiotic therapy. If you would look at your page 638 in your textbook, it talks about nursing management for the newborn with infection. It talks about nursing assessment and diagnosis, looking for subtle behavioral cues of the baby that will indicate that there may be something underlying: temperature instability, feeding intolerance, also hyperbilirubinemia, and the onset of tachycardia. We do want to make sure that we are basing our um, interventions on evidence-based practice and and treating the baby and administering based on the provider orders based on the organism. So remember that before you administer any antibiotic to any baby, you do want to make sure that you get your cultures and any blood draws completed and sent off before you administer the antibiotic. If you give the antibiotic before you find out the organism, and then the lab results come back, you may not have an accurate picture of the organism and what you need to treat. So, care of the newborn with the infection, assess for signs and symptoms of sepsis. Like I said, beware of subtle behavioral changes, temperature instability, feeding intolerance or changes in feeding habits, sudden onset of apnea or bradycardia in an otherwise healthy newborn is indicative of a infection. Proper administration of antibiotics. You do want to monitor for side effects and any toxicity levels. Any antibiotics, for instance, like gentamicin, you need to monitor for levels to make sure that the baby is not getting toxic. Exit, you want to educate the parents on a plan of care and how they can assist. Remember that if they're sick, they shouldn't visit. They should limit the number of people that are visiting, making sure that they're doing meticulous hand washing and hand hygiene, making sure that people that visit the NICU, other practitioners, if somebody's coming in for x-rays or if they're coming into the newborn nursery for x-rays or lab draws or anything like that, that they're also following aseptic techniques. If you have any questions or concerns related to this or any other presentation, please post those questions in the appropriate area in Canvas. I hope that I've covered the topics thoroughly. Again, if you have any questions, please post them in Canvas, and you guys have a great rest of your day.